You're asking how should patients with vulnerable plaques be treated, whether they are echolucent plaques by ultrasound, hot plaques by thermography, soft plaques by other imaging techniques. And I honestly think we don't know. The drug-eluting stent era is very seductive because the restenosis rate is low enough that you don't worry about putting these in. You don't worry about trading off a plaque for a restenotic lesion that in some patients can become even more problematic than a vulnerable plaque. So I do not expect the drug-eluting stent environment to be zero, but I do believe that if you're going to use it to treat a vulnerable plaque, the restenosis rate will probably approach zero. Why do I say that? Because the events and the revascularization events and the restenotic events in the serious trial were actually mostly edge effects, which were probably related to edge disease that was not completely covered. The vulnerable plaque is going to be easier to treat. It's less diffuse atherosclerosis, or at least it's less of a focal buildup in plaque burden. I think it's going to be very easy to spot stent with a drug-eluting stent, and the patients should have one-year events that are very low. But that's only part of the problem, because if we identify a vulnerable plaque today, it doesn't mean they're not going to have another one next year. So they're going to require continued screening and continuous risk factor modification. We're focusing on treating vulnerable plaques, at least people are talking about that. I also think that they have to focus on ways of preventing the occurrence of vulnerable plaques, whatever that histologic substrate is. And that's really going to be, if you will, the pan-arterial treatment, not spot stenting up and down the entire artery.